I mean, the news today is incredibly positive. The reproductive number being where it is, even the worst case scenario projections are so much better than anything we've seen. Dr. Henry, what could undo this? Is there a scenario where this could all go sideways? And what would have to happen for it to go sideways? Would it have to be an explosion of a variant-resistant or a vaccine-resistant variant?
These are the questions that keep me awake and make me anxious every time I look at our case rates and our case numbers and the modeling when it comes up. It is very reassuring. We are in a different place, and it is because, I'm not given to hyperbole, but because these vaccines are so good and they work well and they last, those are the things that we had all of these questions about. And as time goes on, we're seeing what's happening in other countries. We're seeing things like the fact that the antibody response is stronger and lasts for 3 months, 6 months, and that interval that we have, that we made that decision to get first doses into people as quickly as we possibly could. We're now seeing that delaying the interval by as much as 12 weeks actually gives people a stronger, longer lasting effect. So that means that will last us through, hopefully, next fall, next respiratory season. So these are all the things that we're learning as we go, and it is. I am optimistic in a way that I've not been for a long time, and it really has to do with how well the vaccines are working and working over time. And yes, we are concerned about the variants, and that's why I spent quite a bit of time talking about whole genome sequencing and how we are watching every single strain in every single case. And remembering, of course, that it's not just a variant that's out there, it's a person, and it's a person who's infected with a strain of the virus. And we need to watch those. Every time the virus replicates, it changes a little bit. So we could potentially have a strain arise here that has a mutation that means that the vaccine doesn't work as well against it. But that probability goes down and down and down quite dramatically when we reduce the number of people who are infected. And then if we have an introduction, we can stop transmission from that introduction. So yes, we are in a good place now. We need to get our cases down as low as we possibly can before we head into the fall, because we know that there's going to be more virus circulating, whether it's COVID, whether it's influenza, RSV, parainfluenza, all the other things, enteroviruses and adenoviruses that we see in the fall. So we have to be prepared for that, and we know that globally we need to start supporting in a bigger way protection of people in other countries, because every time you see an explosion of transmission and more people being infected, there are going to be variants that arise. And we saw that in India, for example, in Brazil, in the UK. So it's kind of a long way of saying we need to keep our eye on the global picture. We are in a good place now to slowly start moving ahead, as we can see from the modeling that we've been looking at. But there are always curveballs that can come, or as I think Lisa Hughes said last week, bricks to the head. So we are preparing for those. And part of the things that we're doing to prepare is making sure we have public health resources to do adequate contact tracing, that we have the public health lab resources to do whole genome sequencing on every single case, so we know exactly which strains of the virus are infecting people in BC as we go ahead. So those are the things that we'll be watching carefully.
Next question. Bernardo, News 1130.
Hi, Dr. Henry and Minister Dix. I'm just going to follow up with what Shannon was asking about, because you did mention that we are expecting transmission to head into the fall, but how close are we to vaccinating children under age 12, considering that if that fourth wave happens, they won't be protected, and how can we be so fast to ease restrictions when kids are still at risk?
Yeah, so there's a couple of really good things that about earlier today. We know that Moderna has now submitted data for children down to age 12, and we're hopeful that that will be approved by Health Canada very soon in the coming weeks. Just makes things a little more flexible for us right now. But both Pfizer and Moderna are doing studies, what they call bridging studies, down to children as young as 6 months of age. One of the studies from Pfizer was reported out last week. It was looking at the amount of antigen that's needed in different age groups, and so they found that it is just as effective to have a half a dose, so it's 30 micrograms in the adult dose. They're looking at doing 10 micrograms in age down to age 6, and then I think it's 5 micrograms. I have to check my notes, but anyway, smaller amounts in younger age groups. They've started the studies in those younger age groups. Their expectation is that we'll have information on immunogenicity and on safety probably by end of September, October, but before the end of this calendar year. So there is potential both for Pfizer and Moderna to have that information, to have vaccines available for younger people probably before the end of this calendar year. Having said that, there's also some really good data that shows that for every 20% increase in immunization in adults 18 and above, even if you don't immunize children, they are protected. In Israel, some of this came out of Israel, that if you reduce transmission in the community, you're protecting everybody, even those who can't be immunized right now. That's children. So that's important to know as well. And it reflects the approach that we've had, where it protects everybody. The more people more adults who are immunized with the first dose, and the more we decrease transmission in our community. And that protects people who can't mount as good an immune response, whether that's because you're undergoing cancer therapy or you have an immune compromising condition. And we know that some people don't get as good a response even from 2 doses of vaccine. So all of us in the community being protected through immunization and reducing our case rates means that we're all protected that much more, and there's data that supports that from a number of other countries already. So those are the important things for us. If we think about Canada and we think about BC, the proportion of our population that are children under the age of 12 is about 11%. So we can achieve very high protection levels and low rates of transmission in the community that is controllable even without immunizing children. So that's kind of where we're looking right now. I think globally it's imperative for us to protect healthcare workers and adults in many other countries. That's going to protect us all as a global community, and then look to how do we protect children individually as vaccine becomes available later in the year.
Marcella, do you have a follow-up?
I do. I was hoping to ask more about the incentives that are being done to try to get as many people immunized as possible over the summer. I understand Fraser Health is going to be operating some clinics 24/7. So as we see more Moderna vaccine and more Pfizer vaccine being made available, are you planning to make that standard across the province, that we could see in one weekend having a clinic open 24/7?
We could. You know what? This is things that we're doing on a local level. So each health authority is looking at where their communities are. The strategies are slightly different depending on where your population is, and it may not make sense in in Penticton to do a 24-hour clinic. It may make more sense to do a clinic at the farmers market on Saturday mornings, something where a lot more people go. So there is different strategies in different communities. That's one that works particularly in urban areas where people may not be able to get off work. And I know there's all kinds of things that people are looking at. Some of the ones in interior in the north, where we have mobile units that are now driving to different communities and setting up shop, and I understand there was cake and cookies and things available for people at a number of these that were quite popular as well.
Just to to understand that the limitation in delivery of vaccine is not our clinic time. We're delivering vaccine every week that comes to us. At the end of last week, Marcella, on Sunday night, we were virtually out of Pfizer. We kept some for the Monday day clinics, but that was it. So we are using the vaccine we have. So the idea that we could expand capacity, that will happen concurrent with getting more vaccine and finding different ways to deliver it in communities such as Fort St. John, when a lot of workers go off some distance to work and they may come back later. We're looking at models at hours of opening that will assist communities like that. In a community such as Mission, where people also commute farther, often frequently to work, especially in the cases that do into Vancouver, there may be a need to do more in the evening. So we're looking at those kind of variations, but we are delivering all the vaccine that's coming. And I just want to say our teams, and led by Dr. Penny Ballum, it's just been exceptional. The idea that you can deliver vaccine to the most vulnerable, to those clinically vulnerable, to our elders, to Indigenous communities, to small communities in a whole-of-community approach, and to deliver every week the vaccine into people's arms that arrives in large quantities on Mondays, Tuesdays, and Wednesdays is a really extraordinary achievement done by British Columbians who deserve, I think, our gratitude.
We have time for one more question. For everyone listening, Dr. Henry and Minister Dix have released a statement this afternoon with the latest information on vaccinations, cases, and hospitalizations, which you can find at news.gov.bc.ca. Final question to Tanya Fletcher, CBC.
Yeah, Dr. Henry, some people who got an mRNA vaccine want to get the same mRNA vaccine for their second dose. Can anything be done to make sure people who are able to book appointments specifically for the vaccine they first received? So could the system be updated to include information about whether Pfizer or Moderna is being offered at the clinic at the time of booking, or should people just consider the two mRNA vaccines as interchangeable?
Yeah, the bottom line is we have good, strong support that these vaccines are interchangeable. And it's not possible for us to on a day-by-day basis, it's, as we said, it's a just-in-time system with high volumes of vaccine arriving to clinics on a day-to-day basis. And it changes very frequently depending on which shipments come in. And the challenge has been Moderna, quite frankly, in the last little while. So it is trickier for people who received Moderna first to get to be sure that they're getting Moderna, but it should be easier. We're hopeful that later on in June, where more Moderna is available, and our goal is to have both products available at all of the clinics, and so that is what we're trying to achieve. It's not always possible right now, just because of there been the volume of vaccine, the volume of appointments, and trying to get things continuing. And our system is not able to do that on a one-on-one basis, unfortunately.
Tanya, do you have a follow-up?
Yes, please. And if we could get an answer in French for my colleagues from Minister Dix, thanks. You mentioned we'll be transitioning from pandemic mode to living with COVID mode in the fall. Can you elaborate on what that looks like, for example, in terms of daily case numbers in BC? Like, are we talking 100 cases a day, 50, 10? And how will management of the pandemic change, practically speaking, on a provincial level?
Yeah, so from a numbers and data perspective, it will be more, we expect it will be more like how we manage influenza and RSV, which means we look at things like how many cases are we seeing in a week, that we have sentinel surveillance set up so that we can detect it when it's in a community. Recognizing that as rates are going down, we're going to have small numbers and hopefully no COVID in many communities over longer periods of time. So we want to be able to detect when it comes so that we can tell people that, yes, there's some COVID circulating, as we do with influenza every year. And then people need to take certain measures to protect themselves and to get tested and things like that. So we are working on that. How we see it is that this virus is going to be another one of those respiratory viruses that, at least for the next few years, we're going to have to pay attention to. And that means in some communal settings, particularly long-term care homes, we'll need to have our outbreak management and our outbreak plans updated, and people need to be able to rapidly test. And this is a place where, we have rapid testing for influenza in long-term care. We would have the same thing for COVID, and we would have an outbreak response if it was detected. So these are all the things that are this virus is going to be with us. We know that. But it's not going to be able to spread widely. When you're in a pandemic, it's because everybody in the society is susceptible to it. And we've seen how devastating that can be. But what we see, and we can see it already in the hospitalizations and deaths, is that as we protect people with immunization, those go down. And that means we can manage this in the community like we manage other respiratory infections, like we manage pertussis, like we manage measles outbreaks occasionally, like we manage other things. And with public health working with you, being able to stay home if you're sick, keeping it from spreading to those that we're closest to. So those will all be the guidance that we'll be developing with people as we go through these next few phases, and that we'll be looking at how to provide the advice that people need to keep safe over the fall as well.